Hello and welcome to the Evidence-Based Urgent Care Urgentology Podcast. I'm Joe Toscano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB Medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this new program from EB Medicine, the Evidence-Based Urgentology Podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice, and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can subscribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier.
Today on the podcast, we're going to talk about the June issue of Evidence-Based Urgent Care, which was about HIV and urgent care treatment and prevention. We want to thank Dr. Charles Burns and also Sampath Wejasinghe, who authored the initial article.
And also thank you to Dr. Bernie Short, who did the peer review. Let's get started.
We do have some promos to announce. It's Evidence-Based Medicine's 25th birthday in June, but you get the gift. 25% off everything with the coupon code BDAY25, BDAY25. Be sure to check out the abscess course with Patrick O'Malley. This course prepares you to diagnose and treat all kinds of abscesses from chalazions to paronychia, anywhere on the body from head to toe. It includes plenty of video demos, 5 CME credits, and a free incision and drainage practice kit. And you'll find that available at ebmedicine.net. And then one final promo, the keys and clinical pearls for all of Evidence-Based Medicine's 2023 topics in urgent care and emergency medicine are now available together in a searchable digital format. For a limited time, new subscribers to EB Medicine can get that complete bundle called Points and Pearls 2023 Year in Review for free. That is a $397 value. Just go to ebmedicine.net/subscribe.
Awesome. All right. So let's just dive into the article about HIV. So this is a really important topic. Patients with HIV are living way longer than they used to without progression to AIDS. And Joe, we kind of trained at the same time. It's amazing how this has changed in the last few years when we trained. I mean, I remember floors and floors of end-stage AIDS patients, and, there was nothing that we had to offer these people.
Uh-huh.
And now, with all of the highly active antiretrovirals, people are living a full lifespan, the same as they would as if they didn't have HIV. So more and more of these people are going to start coming to urgent care either for other concerns. And by the way, I have HIV, I'm on meds, and we need to figure out how to work that in with everything else, including medication interactions and things like that. And then others that have been exposed and have a lot of questions that we may need to answer, and we may need to figure out how to test and treat some patients who have these concerns. Despite treatment and advances where patients are undetectable, people are still getting the disease. So more than 30,000 patients per year in the United States are still contracting HIV. So definitely worth knowing about from an urgent care perspective. We do realize there's a regional variation. There are a lot of urgent cares that rarely see any concerns related to HIV, but there are some in areas where there are huge at-risk populations, and that may be a more frequent concern in those areas. Again, we must know how to treat patients with the established HIV or AIDS, and how to assess and screen those who were previously negative and now may have had either a potential exposure or have at-risk behaviors that keep them at risk and make them more likely to contract the disease. I just want to comment that the authors did a really good job narrowing down publications that would be of most use to urgent care. There's so much out there. They really focused on guidelines supported by the CDC, Health and Human Services, and as well as the International AIDS Society. So these really have the strongest evidence to support any of the recommendations that are made here. So Joe, how about a review of epidemiology and pathophysiology?
Sure. Well, you talked about the 3,000 new cases per year. And what that adds up to, the last year we have some good data, is that as of 2019, approximately 1.2 million people 13 years of age or older were living with HIV in the US. And in 2021, over 36,000 people received a new HIV diagnosis in the United States plus the associated territories. So that's that 30,000 figure. In terms of pathophysiology, viruses need living cells to replicate, and the HIV virus uses lymphocytes, the CD4 helper cells of the immune system. And in the process of replicating and propagating, it destroys them, and that's what leads to the immunosuppression. Becoming infected with HIV requires exposure to a body fluid from somebody who's infected, and that fluid will have detectable virus in it. And that can get into someone either through direct inoculation into the bloodstream, percutaneously, or via mucous membrane, more likely if the mucous membrane is disrupted. Once the virus is in those cells, local replication occurs, gets into lymphocytes, and then viremia follows. The risk of infection after exposure depends on a number of things. It depends on how much material goes from the source to the host. Also the type of exposure, intact skin, relatively impervious, disrupted skin versus disrupted mucous membrane, or direct inoculation into a vein, demonstrating increasing risk. There are also source factors that are important. The viral load of the source patient, as well as how sick they are at the time transmission occurs, gives you an indication of how much virus is in that infected body fluid that went from one person to another. In that early stage of infection, where a person comes in contact with the virus and it begins to replicate, that is called acute seroconversion. And many patients experience an acute illness during that time. It can be referred to as primary HIV infection or acute retroviral syndrome. And it's kind of scary to think about, but it's very similar to many of the viral syndromes we see in urgent care. Symptoms include fever, headache, malaise, sore throat, lymphadenopathy, and even GI symptoms. So, this overlaps with a lot of what we see, and it really boils down to risk in terms of whether you're going to suspect that among all the other viruses a person could have. That acute retroviral syndrome could last for weeks. People may seek care in the urgent care setting for those symptoms. I don't think about this necessarily right from the start, but I do if somebody's been sick, we're getting into their first week of illness and they've had a bunch of negative tests and, negative for COVID and flu and mono and strep and all that stuff, and they still have those symptoms. You probably think about it earlier, but that's when I start to ask questions about risk factors. So we'll talk some more about that. Trace, what's in your differential for HIV in patients that we need to consider this for?
This is, like, as you said, it's a huge, broad differential diagnosis. For the purposes of this article, they basically divided people into those with known HIV and whether or not they have AIDS. And some people, you have maybe treated partially for AIDS due to noncompliance or some other factors. So you got to ask the questions, it says you're on these meds, are you taking them? Because those patients may have a different CD4 count. They may not be undetectable at that point. So then you have to start considering the opportunistic infection. If they're negative, they may have new diagnosis due to recent exposures. You have to ask about drug abuse because they may have been exposed that way, sexual contact. And then we see a lot of this, at least I do in my clinic, the occupational exposure being down around Disney down here. We see a lot of housekeeping people that got stuck with needles that they found when they were cleaning hotel rooms. And that happens a lot. We see that a lot down here. They have no idea who the source patient is. They just found the syringe and spoke themselves. So again, if the patient has AIDS, you need to be considered about opportunistic infections, things like pneumocystis, mycobacterium kaposi sarcoma, Burkitt's lymphoma, and any other infection that anyone else can get as well if they're presenting with symptoms of some sort of an infection. If they're well treated and undetectable, their symptoms are probably not related to HIV at all. Undetectable means untransmissible and not going to have any AIDS-defining illnesses. So your differential diagnosis would be more or less the same as any other patient that has not had a positive HIV in the past. Exposure, symptomatic and asymptomatic, you want to worry also about other sexually transmitted infections such as syphilis, gonorrhea, chlamydia, herpes. Remember, these diseases travel together in patients that practice high-risk behaviors. Patient concern of acute retroviral syndrome. This may be, as you said, indistinguishable from other viral syndromes, things like hepatitis A, B, and C, Epstein-Barr virus, CMV. Even URI or flu-like illnesses may present similarly to acute retroviral syndrome. Hematologic malignancies, again, can present the same way: fever, chills, night sweats, tuberculosis. So all things that you really need to consider in this really broad diagnosis of viral syndrome. So with all this to think about, where should we start with the evaluation of these patients?
Well, as always, start with the history. As you mentioned, there's a lot of concerns here, and probably the most complicated one is when to suspect HIV in that patient who shows up with a viral syndrome. We'll talk a little bit more about that. And that's where we have to kind of do the detective work. It may be the rare patient who comes in and says, I had an exposure And now I'm sick with something that I'm worried about, acute retroviral syndrome, that usually doesn't happen. We have to figure that out. The more common kind of presenting complaints or needs that people may show up with is that they've had an exposure, either to somebody with HIV or an unknown exposure or occupational or sexual exposure, or they may want preventative counseling or to understand treatment options if they've been recently diagnosed and haven't started treatment. And then there's the issue of general screening. Who should we be doing that for? This section on urgent care evaluation actually opens with the explanation of this concept of universal screening, which means test everybody in the high-risk group. This is potentially important when you consider that about 14% of those people who are living with HIV are unaware of their status. They feel well. They may have the greatest potential to spread it to others because they don't know that they have the disease. If you look at that universal screening concept, the CDC recommends routine performance of opt-out HIV screening for everyone age 13 to 64 who presents to a healthcare setting. It's a lot of patients. The opt-out means you would discuss it with them and they can decide whether they want it or not. And that screening, the CDC recommends regardless of risk. So regardless of high risk behaviors or exposures or anything like that. The U.S. Preventative Health Services Task Force has a similar recommendation, recommends screening everybody between ages 15 and 65. They give that a grade A recommendation. I mean, how many people do we see in urgent care that fit that demographic? So somebody coming in with an ankle sprain, to offer them HIV testing as well. The authors do cite a paper from 2016 showing the feasibility of a rapid point of care HIV test in an urgent care setting. And it was actually a poster presentation at the last national convention in April that talked about the impact of screening in a small population that an urgent care made. It was small, but actually pretty impressive. Of course, it takes a lot of operational, logistical organization to do that, a lot of planning, patient follow-up. So whether urgent care wants to do that or not, or a lot of considerations. We saw how important urgent care was in a public health type utilization during the COVID pandemic, but this would be huge to universally screen all of the patients who it's recommended for. Beyond screening, regardless of what the person comes to urgent care for, the history and exam in urgent care depend on what the patient's concern is. Probably the most common, obvious kind of complaints that I see for this is somebody who's worried about possible exposure, either from a work-related exposure or sexual exposure. It may have been consensual sex or sexual assault. It's important in those settings to ask about the timeline of the exposure and as much as you can find out about the source. Like you said, with the needle stick in a hotel room example, you may not know anything about the source, but if you do know anything, how long have they had HIV? Are they sick? What their treatment regimen is important to risk stratify the patient. Obviously, patients who have AIDS or who are in late stage of HIV disease, who are the source, a lot more worrisome for the contact being risky. And even in those situations, doing an HIV test on the exposed person may not give you much information because most of those patients who are worried present fairly soon after their exposure. So you would expect them to be negative. And actually, if they're positive, it's probably from a prior exposure. Talked about that situation, maybe even the most difficult, where we see an ill patient who may or may not know that they've had an exposure to HIV. And we have to figure out, is this acute retroviral syndrome? In that sea of patients we see with influenza-like illness or COVID-like illness, we have to ask about risk factors. The patient doesn't volunteer them and consider HIV testing in those higher risk situations. This is not the screening where you would screen everybody, but in somebody who is presenting with potential illness from seroconversion. Some of those high-risk factors include somebody who exchanges sex for drugs or money, somebody with multiple sexual partners, somebody who has sex with somebody who is known to have HIV, whether they use protection or not. And also you talked about STIs traveling together. Patients who have more STIs are going to be at a greater risk for HIV just in general. Another category of patient may be one with known HIV and some sort of an acute illness. In this case, asking about whether they know their viral load or CD4 counts, and many patients who are compliant with treatment know that they have a good CD4 count and a low or undetectable viral load. In those situations, you can approach their cough or sore throat or their cellulitis just like you would any other patient. Knowing what their treatment is and whether they're compliant is important. Again, those things kind of fit together. Compliant patient knows their regimen, they know their viral load and their CD4 count. CD4 counts that are greater than 20 cells per microliter are good. Again, you would treat that patient and in terms of your differential and your further questioning and exam almost as if they didn't have HIV. But in the flip side of that, if they don't have a lot of that information or are not compliant, you really need to crank up your spidey senses for whether HIV is a part of their presentation or complicating their presentation. And the paper is important to emphasize that even though patients are living longer and even normal lifespans, when they're compliant with treatment, they are at increased risk for a number of kind of inflammatory and vascular issues. So they do have a little bit higher risk of cardiovascular disease, neurocognitive disease, liver and kidney problems, and even some malignancies. So it's important to factor that in a bit when you're seeing the patient with chest pain or dark urine or those sorts of things. And then I think probably the hardest patient is the one who you just don't know what their HIV exposure was, and then they have acute illness. That's probably lurking in the background in a lot of our patients, and it's just important to ask risk factors. Those patients who present with later stage HIV, whether they know they have it or not, you may be able to find some physical exam findings like oral thrush or Kaposi sarcoma, cachexia wasting syndrome, extensive oral ulcers. Those can be a clue that the patient has HIV, again, whether they know or not. There is a correlation between substance abuse disorder and HIV infection. So that, again, is going to crank up your index of suspicion a little bit more if you know that they abuse substances. And then finally, thinking about just your approach in history and exam, with a chief complaint of diarrhea, knowing that the patient has HIV, again, if they're compliant with meds, CD4 count low, viral load, you're going to treat them like anybody else. But somebody who isn't, they're going to have a wider range of potential infections. You're going to consider testing for those things. And then the interesting thing about the compliant patient is that diarrhea can actually be non-infectious and is not an uncommon complication of HIV meds. So keep that under consideration. So wow, a lot to think about. Beyond that presenting complaint and our history and exam, again, we're starting to be concerned about HIV. Where do we go next?
Well, again, based on the patient and the situation. So say someone comes in and they're asking about prevention. They have some high risk behaviors. Their partner is positive, maybe. They're not sick. They're currently negative. These people might be a candidate for PrEP. PrEP being pre-exposure prophylaxis. So there are a lot of people that are eligible for this that are just not doing it, probably because of the lack of education and knowledge that it exists. Urgent care is really in a great position to either start this, continue as this, or even just plain educate them about this. If you don't feel comfortable starting these meds on patients, then you should know where to refer people to that do them. There's several oral meds for pre-exposure prophylaxis. There's some injectable meds for pre-exposure prophylaxis. You have to make sure it's a patient that really has good follow-up and is going to be very compliant. They should be regularly tested, I believe it's 4 times a year. And then again, they have to be compliant for effectiveness. I think that's where the injectable one comes in really good because you only have to have it every 2 months. So it's not a pill that you have to remember to take every day. So definitely useful for people with either high-risk behavior or have regular exposure. Concerns post-exposure, these can be divided into occupational and non-occupational. The post-exposure occupational generally would be someone who's at work and somehow got exposed. So whether a healthcare worker, the housekeeper that we were talking about, sometimes groundskeepers, law enforcement, teachers. So sometimes I've seen a fair amount of teachers that have been either bit by students or going through someone's locker and got poked by something. Law enforcement, especially corrections officers, there's a lot of exposures that I've seen from them. So you really want to try and assess the person that exposed them, the index patient. You really need to see if you can get any medical history on that person. You know, obviously, if it's someone in a prison, their captive audience, you're going to have their medical records. But if it's someone like we talked about with the housekeeper, you're not going to have those medical records. Timing's essential. If we're going to be doing some post-exposure prophylaxis, you really need to start it within 72 hours for it to have any effectiveness. The other way is the type of exposure that you had when you're talking about these things. You know, was it a large bore needle? Being stabbed with an 18 gauge with visible blood in it is probably a lot more significant than having someone's spit splash on your arm. Much less likely to have an exposure then. So you really kind of have to tease this out and figure out how much exposure there was and really what the risk is to decide whether or not. And basically, you just provide the patient with all the information and what you think the risk is and let them make the decision as whether or not they want to take the post-exposure prophylaxis. The patients we see with non-occupational exposures, generally unprotected sex. So either the barrier failed, they were assaulted, or they're doing drug use in some way, intravenous drug use, and somehow being exposed to needles. You want to assess the partner if possible. But don't delay. You don't have to wait for that. You know, that again, that 72-hour window applies here too. You can always stop if you later find out the donor is HIV negative. So, if you're sending it to the lab or it takes you 3 days to track the person down and then you send it to the lab, but it's a good idea to start the patient on post-exposure prophylaxis if you feel that it's a high-risk exposure. So outside that 72-hour window, all you can really do, counseling, recommend that they get their regular follow-up testing to make sure that they don't convert. And you want to instruct them on signs and symptoms of the acute retroviral syndrome because you want them to know if they're suddenly becoming ill and when they should seek medical care. If it is someone that's going to continue to be exposed, you want to maybe mention that pre-exposure prophylaxis is a good idea for that person, and either consider prescribing it or once you've determined that they're negative, or you want to refer them to the appropriate person to counsel them and start them on PrEP. So non-pharmacologic pre-exposure or post-exposure prophylaxis education. Education is the key to everything. Knowledge is power. The more people that have been exposed or are at risk for exposure to HIV understand what's going on, the more likely are they going to make an informed decision that's right for them. Barriers are encouraged. You always want to recommend condoms if you're having sex that is not your single life partner. Lower risk sex, such as oral as opposed to penetrative. Again, we were talking about mucous membranes that are disrupted. Penetrative intercourse generally can cause that disruption and is higher risk for exposure than giving oral sex. Circumcision, men who are circumcised are more likely to sustain trauma to the area and to contract HIV from little micro tears in the area than men who are not. Intravenous drug abusers, probably not going to be able to get them to stop using drugs while they're being seen in urgent care for that one visit. But at least you can suggest to them, hey, try using clean, not shared needles. That would be a great way to significantly decrease your risk from getting HIV. So, Joe, what kind of testing do we need to consider in these people? Somebody shows up, how do you decide what tests you want to order?
Right. Well, 2 points here. When you have that patient who's known HIV positive, compliant with treatment, low viral load, CD4 count greater than 200, the tests that you're going to do for that patient don't necessarily concern their HIV, but if they come in with sore throat, cough, fever, abdominal pain, dysuria, you can work them up just like you would anybody else. Swabs, X-ray, urinalysis, cultures, those kinds of things. When you have your non-compliant patient, known HIV, or they have a high viral load or low CD4 count, the testing is probably beyond what we can do at urgent care because you need to consider opportunistic infections, and truly any real sick patient probably need to be referred to the ED for that sort of testing. In terms of testing for HIV in those situations where an exposure has occurred and a patient wants to know their status, there are several tests that are available. There are actually some rapid point of care tests. They involve oral swabs or blood specimens. You can get the test result back. There's an advantage to that in that you'll get an answer relatively quickly and you can proceed. Some false positives, false negatives. With that, it's recommended that any positive test on a rapid is confirmed with our best test, which is a 4th generation HIV antibody P24 antigen test. This is kind of a neat test because it picks up the antigen at an early stage. It's not the same thing as an HIV PCR, which is the very earliest positive test that will show that somebody's had exposure and is becoming infected, but it's the next best one. And then as well, it has an antibody component to it. So somebody who has in that phase where they're producing antibodies, you'll be able to pick that up as well. It's really the gold standard test. The HIV PCR test should be used if you're really concerned and it's very early after an exposure. All of these tests have what's called a diagnostic window. There's a time period from exposure till when you expect the test to be positive. So for example, the rapid test will turn positive anywhere from 23 to 90 days from the exposure. The finger stick one, a little bit better. It's a blood specimen, turns positive from 18 to 90 days after exposure. A good antibody test that you would get from a phlebotomy specimen is going to turn positive between 18 and 45 days. That HIV PCR tests for HIV RNA, and that will turn positive as early as 10 days after. So tailor the test to the exposure situation, but also know that if it's really early after exposure, you are going to get a negative test from that exposure, and the patient's going to need to repeat their tests a week or 2 later to know what's going on. Whether you begin treatment for them or not depends on your risk assessment in those situations. And then finally, I think I always learned something from reading these, but something that I really didn't truly know was that patients, even with well-controlled HIV, we need to consider them at a little bit higher risk for coronary disease, venous thromboembolism, COPD, other things like that. And so you can have a lower threshold maybe for doing an EKG, or if you can do a troponin on a younger patient with HIV if they come in with chest pain. In the risk management pitfalls section of the issue, they talk about a 42-year-old with longstanding HIV that's well controlled, but he comes in with chest pain and actually has ACS. So I think that's important to keep in mind when you're risk stratifying patients and deciding on tests. How about treatment trace? What's the evidence base for this? What are some treatment concerns for all the varieties of modes of treatment for HIV, PAP, PrEP treatment, those sorts of things?
All right. Well, a full in-depth description of all the specific different meds is really kind of beyond the scope of this. So we're just going to be a little general, but basically you can divide what we're talking about into treatment of those that have HIV, treatment of those who have been exposed and need post-exposure prophylaxis, and treatment of those who are at high risk for developing HIV and will get pre-exposure prophylaxis. So first of all, speaking about patients that have HIV, current guidelines say anybody that tests positive for HIV, regardless of their CD4 count and viral load, should have suppressive treatment. This is the best way of preventing progression to AIDS and keeping the patient healthy with a normal lifespan. If you identify a HIV positive patient in your clinic, you should start them on HIV meds right then and there if possible. If that's not something you feel comfortable doing, please make sure that you arrange for them to have follow-up as soon as possible within a few days to get started on those meds as soon as they can. Maybe figure this out in advance. Figure out the phone number for your local health department HIV clinic so that you'll have like a business card to give a patient if they test positive, because that is key to keeping the patient healthy for a long lifespan equivalent to other people that don't have HIV. It's very reasonable, like I said, to start the first fill, give them a month's supply in urgent care, and then they can get their long-term elsewhere if you can't get them in to see anybody. Again, local health department, HIV clinics, ID clinics know this ahead of time. We may get people into urgent care that need refills on HIV meds. I see patients that need refills on stuff all the time, and I'm sure most of your urgent cares do too. It wouldn't be bad to give patients a 1-month bridging prescription for their HIV meds because it would actually do more harm to have them off of it for a month.
Mm-hmm.
So don't be that person who says, no, I'm not giving that refill. Give them the refill because it could save their life or prevent their progression.
Right.
Post-exposure prophylaxis, again, you got 72 hours. Once it's past that 72 hours, it's not going to really help prevent conversion at that point. So start that treatment while you're awaiting labs or testing of the source patient. Don't let that 72 hours run out. You can always stop it once you've started it. The new meds are much more tolerable. As someone that took AZT in the past, I can tell you that was a horrible, horrible experience.
Mm-hmm.
The newer meds are not horrible at all. You maybe have a couple days of nausea and vomiting until you get used to it. And then it's just like taking a vitamin for a month. You want to make sure that you have close follow-up once you've started these meds. And you want to do repeat testing at week 4 and 12 to make sure that they haven't converted. Don't forget about co-infection testing if you've got exposure from sex or intravenous drug abuse. And don't forget about pregnancy testing if you have a female. Again, can't say it enough. Make sure you do that repeat testing at weeks 4 and 12 if there's an exposure. You can't just say, oh, you're HIV negative, because that test was taken before that person would have converted after an exposure. So always make sure that they have some close follow-up. Again, if you don't feel comfortable doing it in your urgent care, make sure that you refer that person somewhere where they can get that adequate follow-up. Hepatitis testing, again, if the patient is someone who injects drugs, then you want to make sure that you do the hepatitis testing, both for B and C. And if they come back negative for hepatitis B, you want to consider vaccinating them for hepatitis B when you do the follow-up. Talking about PrEP, pre-exposure prophylaxis, there's 3 options. Again, there are 2 oral combinations and there's 1 injectable combination. The orals actually come with multiple meds in 1 pill, so you don't have to worry about taking multiple meds. Again, the description of each one is kind of in-depth and beyond the scope of this, but if you're really interested, look it up. There's plenty of good info on the CDC websites or in various other sources, this article, for example, but lots of other sources to find this stuff out. Patients should be screened before initiation of PrEP and counseled appropriately. Again, this is a great thing to do in urgent care if you have the bandwidth to do that. If you do not, then please know to refer these patients to that are requesting PrEP. The HIV could be prevented by the PrEP. Discontinuation of PrEP. Some people will stop it. This can result in reactivation of hepatitis B if they had it. There is some crossover with these medications where they will suppress hepatitis B. And when you abruptly stop the discontinuation of the HIV meds for PrEP, you can have this rebound hepatitis phenomenon that can be so severe, the patient can actually get an acute hepatitis that's fatal. So always counsel patients, don't stop your PrEP abruptly. Make sure that you get the advice of an infectious disease doctor before you consider stopping your PrEP. HIV meds, like I said, are pretty tolerable now compared to the earlier meds, but there are some side effects. Nausea, vomiting, and headache are usually the most common. They're worse at onset, and they usually resolve in a few days to weeks. And you can treat that with the usual meds. You can give ibuprofen for headache if you want. You can give them ondansetron for nausea, vomiting if you need to. That's fine to do that. Some patients are very nervous about the nausea and vomiting because they've heard of other people that have had that secondary to post-exposure prophylaxis. Give them a few days of ondansetron. So beyond that, Joe, how about talking about some of the special situations an urgent care clinician might encounter regarding HIV in urgent care and any cutting edge stuff that might influence what we do?
Sure. Well, we talked about the correlation between substance abuse disorder and HIV infection, particularly in those who use injection drugs. When you have that patient with both of those, it's just going to be a more complicated situation. Those patients who have substance abuse disorders, also mental health issues, a lot less likely to be compliant with treatment, more disruptions in continuity of care, a lot less likely to continue therapy or obtain tests. Not, immediately solvable. It's just important to understand it's another social determinant of health that if you have the ability to make a referral to a social worker, or if you have an ambassador in your program to offer that person extra help to navigate this really complicated situation. The other kind of special situation, I think, is whenever you have to announce to a patient a new diagnosis of HIV. It's important for us to be very mindful of the impact, even though, like you said, in the 80s, this was much, much different disease. I think people still think of it as maybe a death sentence or something that they're going to have to live with and it's going to complicate their life. So make sure that it's not like standing at the doorway and say your strep test is positive. You need to do this in a private location and provide for adequate time to address questions and concerns and plan for those next steps. Most urgent cares don't have social workers, but if you're in a situation where you do, this is, that new HIV diagnosis, a great time to involve a social worker if you can. One of the other special circumstances, you alluded to this, is a patient who is uninsured or underinsured. The meds can be somewhat expensive. It varies by state, but most states do have help for patients to pay for these medications. And it's important to know those ahead of time so you can get people plugged in relatively quickly based on the options in your area. Again, starting treatment, not stopping treatment in patients who need refills is really important. And then we talked about the injection meds, and there are actually some pharma companies that are working on long-acting injectable options for both HIV treatment and PrEP. And this obviously will make compliance much easier when having to take a pill or multiple pills a day. A long-acting shot may last for months, so compliance will go way up. We probably won't be giving those in urgent care, but mentioning to patients and knowing where they might be able to avail themselves of those options would be one of the things that we could do to help. So how about a summary and laying on some points and pearls, Tracy?
Oh, absolutely. So for initial HIV infection, remember it's a non-specific type acute viral syndrome. Acute retroviral syndrome is an acute, non-specific viral syndrome. So you really have to have a high index of suspicion to make the diagnosis in patients that are at risk. Consider asking people about screening. All patients aged 13 to 65, again, they started recommending that a few years ago. Our urgent care was really gung-ho about it for a while, but so many people said no. I think people just kind of stopped asking. So maybe we should start bringing that back, at least in those patients that we're considering them to be high risk. Pregnant patients should all have HIV testing. Anyone who has multiple sexual partners or men who have sex with men or patients who are drug abusers should all have screening as much as possible. And if you can offer that to them out of an urgent care setting, that's great. Don't forget to screen for the co-infections, STIs, hepatitis. Best testing is that 4th generation test for HIV antibodies and the P24 antigen. From urgent care, that's what we should be ordering and sending out. It's positive within 2 weeks of exposure. And follow-up with testing is important. Don't be done at the first negative test 5 minutes after exposure. You got to make sure you do those follow-up tests. Concerned about acute HIV, consider PCR testing. Remember, that's positive earlier than that 4th generation test, usually within about 10 days. GI upset and headache can result in non-compliance with meds. So treat that if necessary and reassure the patient that that's going to go away in a couple of weeks. You should really stick with the medication. It's very important. Stopping drugs abruptly, as in PrEP, can result in a fatal hepatitis B virus flare. So if someone comes in and is requesting a refill, please give it to them. We don't want them to have that fatal hepatitis B flare. Many people who are eligible for PrEP are not taking it. The key to that is education and counseling. So if you come across someone that you think would be a good candidate for PrEP, please counsel them about it. If you can't do it yourself, start it yourself. please refer them appropriately. Don't forget there's a correlation of substance abuse with HIV. If HIV positive patient needs refills on their meds, please provide a bridge until they can get a refill, because stopping it does more harm than good. Really good information if you want to go looking for this article, but also the CDC website. And then on that CDC website, there's HIV Nexus information and a lot of tools for clinicians, a lot of things where you can plug in, when the exposure was and what tests should be done and what meds are best and when certain diseases present with CD4 counts and things like that. So how about some final pearls, Joe?
Sure. Keep in mind that treatment adherent patient, compliant, can have a normal life expectancy without opportunistic infection. It is important to keep in mind, though, that even somebody who is well controlled in terms of their HIV infection, compliant with meds, they do have a chronic inflammatory state. So it leads to a higher risk of cardiovascular, pulmonary, renal, neurologic, GI, hematologic, endocrine, musculoskeletal, psychiatric, and derm disease. So just keep in mind they're higher risk for that, even if they're well controlled with HIV. When the patient is aware of them, and again, that's usually going to be your compliant patient, knowing the CD4 count viral load can help you risk stratify and narrow your differential diagnosis when the patient presents with some symptoms that are worrisome for infection. Is it an infection that a person with a normal immune system would get, or do I need to worry about opportunistic infections? And that's when that data is important. In those patients who you're going to offer post-exposure prophylaxis, do it as quickly as possible. You want to do it within 72 hours, but as quickly as you can to get those first doses in and make sure the patient has a supply of meds. And then the final pearl is that patients with any STI are at higher risk for HIV, and you should consider them as candidates for PrEP.
Perfect. So in conclusion, an urgent care center or urgent care clinician can play a crucial role in the diagnosis of HIV and management of exposure. So remember, again, for the 15th time, because it's important, exposure should be treated within 72 hours if you're going to do post-exposure prophylaxis. We are really in a unique position to provide education about PrEP and other forms of prevention, even if we're not providing it. So learn about it and mention it when you have patients that are presenting with either STIs or concerns about exposures. We can also do screening for HIV if we need to. People now have longer, if not normal, lifespans with HIV, so it's important to identify them as soon as possible. And in this day and age where a lot of people are getting their medical care from urgent care and not from primary care doctors, we are uniquely situated to take the reins on this. There are more and more HIV positive patients in the community that are being treated, who are going to present to our urgent cares with illnesses that may or may not be related to their disease, but it's something you really need to think about when they come in for complaints. Is this related to their HIV? Are they compliant with their meds? Is this AIDS? Is this not related at all? Will their meds interact with whatever I'm prescribing? Requires a little bit of thought when you're taking care of patients that are HIV positive on medication. You want to know what their viral load and CD4 counts are. Are they compliant with meds? And you want to make sure that patients who are either undiagnosed, untreated, or non-compliant are assessed for opportunistic infections when they present with certain complaints.
Great wrapper. Well, thanks again to our authors and reviewers. We hope you enjoyed the discussion, learned something, and we'll be ready for more soon.
Yep. Coming soon to a EB medicine near you. Shoulders. So gotta love shoulders. They're always fun in the urgent care center trying to sort out what the shoulder injury is. So please feel free to go to ebmedicine.net and use that 25% off coupon for everything. Coupon code BDAY25. And check out the abscess course with Dr. Patrick O'Malley. With the video demos, it's a really great course. I've actually seen it. It's awesome. You get 5 CME credits and a free incision and drainage practice kit, which is really cool. He designed it himself. And then the EB Medicine Complete Bundle, which includes EM and urgent care with the points and pearls for 2023 year in review. That's free in addition to your complete bundle, which is usually $397. All of this is in searchable digital format, and you can go to ebmedicine.net/subscribe. Thanks for listening to our podcast, and we'll see you next month.
Take care, everyone. Bye-bye.
I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to ebmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's ebmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.